Okay. I think we were waiting for a couple other folks who are still downstairs, but I think we may just get started here. Looks like they're coming in now. Great. So first thing I want to tell you is that there's going to be 3 talks this morning, and if you can hold your questions until the end and write them down, and Paige, very nice woman who'll be in the back there, will be collecting those questions at the end, and then we'll use them as part of a discussion after the 3 talks. Okay? All right, I think I'll get started here. So welcome and thank you for spending your Saturday morning with us, and we really appreciate your enthusiasm and for coming out to hear us speak today. And we're going to talk to you today about a new program at Stanford that launched just in July and really got going in August that we're very excited about, and we hope that we can share that enthusiasm with you today and answer any questions that you have about what we're doing. So the title of my talk is Heart Disease in South Asians, a Global Epidemic, and my name is Rajesh Dash, and I'm the Medical and Scientific Director of the Stanford South Asian Translational Heart Initiative, otherwise known as SSATHI. And SSATHI is intended to be a program that begins here at Stanford, but will hopefully soon extend our efforts in both clinical and research activities to South Asia, if we are so lucky to do so. And today I want to talk to you briefly to introduce coronary disease risk in South Asians, what the SSATHI clinic and research goals are, what goes into our comprehensive cardiac risk assessment, and what differentiates us from other programs in terms of the SSATHI difference. Before we jump into that, though, I want to talk about a typical SSATHI patient. In fact, this was the very first SSATHI patient we saw back in July. So KS is a 42-year-old male engineer living here in the Bay Area with no prior history of heart disease. He actually came to me complaining of occasional shortness of breath. It wasn't really exertional, but it was of some concern to him, and I'll explain why in a moment. And I asked him about exercise. He said, sure, I exercise. I exercise about 40 minutes 3 times a week. And I said, well, what do you do? And he said, oh, I do aerobic activity. I play cricket. And I don't know if any of you, I'm sure most of you have maybe seen cricket. It might be aerobic activity for 1 or 2 people at a time, but it's certainly not continuous activity. So I kind of viewed that as plus minus. He said he smoked occasionally, socially. His blood pressure was kind of borderline, 130/85. And he gave me some old labs that he had, and that showed that a fasting sugar level, or glucose, was 104, which is just in that borderline range. And a measurement of diabetes was negative for diabetes. It was kind of 5.5, and 5.7 we consider to be borderline. And he said his cholesterol was normal, and actually his standard lab test did not show any abnormal cholesterol. So he had gone through a stress test before he came to see me, and they had told him it was somewhat inconclusive. They hadn't been able to rule in or rule out a problem. And he had actually refused to undergo an angiogram when he was advised to do so by his other doctor, but he came to see us for a second opinion. So what I'm showing you now is a commonly used tool in our clinic and others, which is the atherosclerotic cardiovascular disease risk assessment calculator. And it forces you to type in various pieces of information about each patient, whether you're male or female, what your cholesterol levels are, whether you are treated for high blood pressure, whether you're a smoker. The interesting thing is over on the right, if you look, there's a category for race, and it's either white, African American, or other. And other is a pretty big category, as you might imagine. And even using other for him, he had sort of a lowish risk, 4.9% over the next 10 years of having a cardiovascular event, and 50% over his lifetime. And actually, based off this risk, as you'll see, they don't recommend any treatment for him by this calculator. But the other thing I want to draw your attention to is this disclaimer in the bottom right corner. It says that South Asians may have a higher risk, and that's not accounted for on these scales. And that's a thematic thing amongst cardiovascular medicine, is that we don't correct what we do for the average patient for the South Asian risk that we know is higher. So for instance, with that designation of white or other, he was not in the statin benefit group due to a low 10-year risk. So then I started to ask him about him and his family, and here he is on a family pedigree. He's the square here that I've drawn another square around, and I asked about his relatives, if anyone else had had heart problems. Well, he said, well, yeah, my brother just had a stent. He's 46 and I'm 42, so that's one of the reasons I wanted to come see you. I was like, oh, that's interesting. That's an early age to have a stent. So he had actually had a heart attack and a stent, and he was very concerned about him. And then when I asked him a little bit more about his family, it turns out that both his brother and his mother had had heart attacks and stents. In fact, his mother had had 4 stents, and he had had 3 uncles on his mother's side die under the age of 60 from heart attacks. And sadly, this is not a rare problem in the South Asian community. We did a coronary CT on him because he still did not want to have an angiogram, and this is his left anterior descending coronary artery, and what you see here is a near complete blockage of that artery in the mid portion, and this is again the major coronary artery of the heart, and this is another representation of it here. So he underwent a stenting procedure and is feeling much better now after he had that done. But the question he asked me when I saw him in follow-up was about his son and his daughter. He said, why did this happen to me? How can I prevent it from happening again? And how can I protect my children from this disease? So coronary disease risk in California is markedly skewed in the South Asian population, 4 times the number of heart attacks and strokes and sort of chest pain admissions to the hospital. Extremely high rates of prediabetes, like insulin resistance, as well as diabetes, metabolic syndrome and lipid or cholesterol abnormalities, and inflammation in the body. And the early heart attack is a theme among South Asians. More than half of all heart attacks are occurring under the age of 50 in the South Asian population. This is not limited to just California, obviously. In India, over 50% of the world's coronary disease burden is in India, according to the World Health Organization. And South Asians develop coronary disease about 10 years younger than any other ethnic group. We tend to have more severe coronary disease at presentation, a higher incidence of high-risk blockages and multi-vessel blockages at first presentation. And in the 2000 California census, this is somewhat old data, the only group that had a lower life expectancy than the prior census was South Asian women. So this is not confined to men, and I encourage all of my patients when they come in with their wives to have their wives come in too, because they are at just as high of risk. The other interesting thing is that after a first heart attack, South Asians are 40% more likely to die from that heart attack than other ethnic groups in their first heart attacks. So, coronary disease is the #1 killer of South Asians in both the US and in India and other parts of South Asia. It's more prevalent, more aggressive than in other ethnicities, and South Asians in the younger age group, 20 to 55, can be considered intermediate to high risk when you consider some of these other factors. So what are those risk factors, non-traditional and traditional ones? Well, the traditional ones still apply, and Dr. Nalam Shetty and Dr. Abbasi will be speaking after me about some of these risk factors. But tobacco use, high blood pressure, lack of diet, lack of dietary control and lack of exercise, cholesterol abnormalities, obesity, diabetes, they're all known to be correlative in South Asians for having coronary events. The BMI cutoff, the body mass index cutoff is probably lower for South Asians. 25 is what we use for the general population, but 23 is really more applicable to the South Asian population. But what about non-traditional risk factors? Visceral fat accumulation. This is fat that you can't see looking at someone. It's on the inside along the organ's surface, is a known risk factor for cardiovascular events and is higher in South Asians. Inflammatory and dyslipidemic biomarkers like lipoprotein(a), HDL2B, ApoB100, PAI1 these are all inflammatory markers that are known to be abnormal in South Asians, and insulin resistance, and you'll hear a lot more about these today. Insulin resistance is something we focus on, and Dr. Abbasi will give us a lot more information about that. It's rarely tested for. It involves the tissue response to insulin, and it's one of the precursors to diabetes. You may have normal lab values. When you come into someone's office, you may have a borderline glucose and a relatively normal A1C level, but you do a special test for insulin resistance and you'll find it to be abnormal. So that progression to diabetes doesn't happen immediately necessarily, and there's some data that South Asians may actually not progress to diabetes as quickly, and they may hang out as insulin resistant, yet insulin resistance is itself associated with atherosclerosis, endothelial damage, and cardiovascular events, and insulin-resistant patients have a similar rate of cardiovascular events as actual diabetics. So that is something that needs to be diagnosed and needs to be addressed. And they can be through lifestyle, diet, and medical therapy. Diagnosis is difficult, and it's something that many places are not willing to do, but that's something that we really dedicate ourselves to doing in the SSATHI clinic. And you'll hear more about that testing soon. So for traditional risk factors, South Asians do have a high rate of traditional risk factors as well. However, they tend to underestimate the coronary risk in this population, and you'll hear more about that from Dr. Neelam Shetty. Whether you use the Framingham risk, Reynolds risk, Q risk scores, they all seem to underestimate the actual incidence of events in South Asians. So we need to go beyond that to the genetic, cultural, dietary, and social, as well as migration factors of this population. We feel that insulin resistance as well is a major untapped diagnosis right now, and a potent one in terms of the risk for South Asians. So we feel like non-traditional screening is going to add value. So what is SSATHI, and how are we tackling this problem? SSATHI, our mission is the early identification, prevention, and treatment of heart disease in the South Asian community. SSATHI means companion or friend in many South Asian dialects, and our target population is the younger population, although we see patients of all ages in our clinic. Our goal over a 6-month period and 3 visits is to reduce someone's heart disease risk to its lowest levels possible, and that begins with an initial clinical risk assessment. If someone's having active chest pain, we're going to deal with that right away. We're going to do diagnostic risk stratification, and short-term goals are going to be set from a dietary and medical standpoint, and at week 6 or 8, they'll come back. We'll review their clinical diagnostic testing results, whether those are blood tests or stress tests or CT scans or what have you, and we'll provide an initial risk score for them that we feel adequately reflects their South Asian specific risk, provide dietary counseling, and engage them in something called the cardinal commitment. The cardinal commitment is something that's Stanford medicine-wide, which is that we will do everything in our power to prevent an event for you if you are committed to doing what we ask you to do from a lifestyle and medical standpoint. And that's something that Alan Young, our division chief, has really been a proponent of, and we've all followed suit. And also at that second visit, we will do a research enrollment, and part of that research enrollment involves an oral glucose tolerance test to look for insulin resistance, to stratify patients into pre-diabetic or not. We then review at the 6-month time point the research results of the patient, the dietary follow-up, a repeat risk screen, and a repeat risk score, a revised risk score, and develop a long-term SSATHI care plan for each patient. And that's going to be different for every person. We might not need to see someone for a couple of years, or we might need to see someone in a couple of months, depending on what their level of disease burden is. The other thing I want to emphasize, and hopefully your heart disease risk is at its lowest levels by the 6-month time point, that our clinic is really at a center of Silicon Valley, and Stanford's faculty are actively engaged in bringing wearable devices and tracking technology to our patients, and that's something that we are hoping to implement this year with our research program in order to capitalize on this wave of medicine that is really sweeping the country in terms of real-time data stream integration with our patient care. So I mentioned some of the non-traditional risk factors. I won't spend too much time on that today. One other thing I should mention is that we also know of some genetic mutations that are prevalent in the South Asian population that are associated with higher risk of coronary disease. And these are things that we can and are screening for in the SSATHI clinic or as part of the SSATHI research program. So first, I want to go through who you may actually see on your first visits to the clinic, and those include Abha Khandawal, who's also part of the Women's Heart Health Clinic, and she's actually giving a talk downstairs right now. Myself, Monica Divakaruni, who's also an interventional cardiologist, and Sri Nalam Shetty, who is preventive cardiology and is a very valuable addition, a recent addition to our faculty just a few months ago. I also want to highlight Dr. Abbasi, who is as of just recently added to our clinic team. Dr. Abbasi has over 15 years of experience in treating insulin-resistant patients and is an incredibly invaluable resource to our efforts in SSATHI Clinic. And we have a whole host of specialists in the cardiovascular medicine department, from heart failure to pediatric cardiology, electrophysiology, heart failure transplant, and non-invasive genetic specialists like Dr. Assimi's. We have cardiac surgery colleagues and vascular surgery colleagues, and Dr. Chandra has actually been screening patients with ABIs. Maybe some of you met her this morning. And of course, without our support team, we would be nowhere. So our nurses, our practice care coordinator, and our dietitian are all integral parts of our team. So in addition to our clinical mission, we have a research mission, innovative research into the genetic and physiologic underpinnings of disease. And we're hoping to bring that mission not just to our patients here, but globally. So we're working closely with the Stanford India Biodesign Program, with Narayana Health Systems in India, as well as other health programs in India, to try and harness some of the technology that we might be able to provide to that part of the world. And of course, we work with some of the core labs at Stanford to look at some of the genetics and hopefully comparative genetics between populations in India and South Asia, as well as here. That structure is integrated with our clinical approach, and on that second visit, you'll have an opportunity to join those studies. And those studies are of no cost to you, but we're hoping that you'll be interested in those. One of the things that we are doing is cardiac MRI for patients. This is something that is a relatively new modality for cardiac evaluation on the grand scheme of things. And in terms of what it can do, it can look beyond just your standard heart function and size. It can actually look at any evidence of fibrosis, fat, or strain in the heart. We're also doing stem cell work where we can take a patient's immune cells, turn them back into stem cells, and turn those stem cells into heart cells, liver cells, pancreas cells in a culture dish, and look at individualized drug responsiveness in our patients and study insulin-resistant versus non-insulin-resistant South Asians at that level and understand where those abnormalities may come from. Personalized medicine, as I mentioned, some of the wearable devices and how they may integrate with our research efforts. And now Stanford Medicine has recently launched a health app that will integrate, hopefully, with devices in the future. There are some major announcements being planned that I can't speak of right now, but in the next couple of weeks, you will hear about these. And again, the research program is completely voluntary, studying mechanisms of new treatments and disease, and enhance our individual risk assessment through the following several different research studies that we're doing. So how are we different? What you should expect is an expedited appointment with us, long-term heart and vascular care with feedback from MDs and dietitians at each visit, proactive screening and treatment, long-term risk reduction, and access to the latest research and technology, as I mentioned before, and specifically collaborations with our excellent colleagues at Stanford. We're right next to campus, Alpine Road. Parking is free and easy, and I think you have information if you're interested, so thank you. And I'd like to introduce now Dr. Fahim Abbasi, who's going to speak to us about insulin resistance. Thank you.
Good morning, everyone. Thanks for being here this morning, and Today, I'd like to talk to you about insulin resistance and metabolic disease and how they contribute to risk for heart disease in South Asians. So as we just heard that diseases of heart and blood vessels or cardiovascular disease is very common in South Asians, and as an example of that, I'd like to show you results of a study that was conducted in Canada in which 3 groups of individuals were assessed for presence of cardiovascular disease. And essentially what the investigators found was that South Asians had 2 to 4 times higher risk for developing or having cardiovascular disease. So this is something that, as Dr. Dash mentioned, it's a big, cardiovascular disease is a big problem in South Asian individuals. And not only the heart disease is more common, but it develops at an early age and it's severe at the time of diagnosis. So one of the things we are interested in is finding out that what leads to this higher risk for heart disease in South Asians. So what we do is we approach it by looking at risk factors. And risk factors are basically conditions or features or behaviors that are present in healthy individuals that over time lead to a disease. And one of the conditions that we're interested in is insulin resistance. And the reason for looking at insulin resistance is twofold. One is that insulin resistance is associated with several metabolic abnormalities that over time can increase a person's risk for heart disease. And secondly, people originating from Indian subcontinent or South Asians are more insulin resistant as a group. So what I'd like to do is, over the next few minutes, tell you what insulin resistance is and how does it cause diabetes or heart disease, and which factors influence insulin resistance, and how can we be more aware of its presence. So to understand what insulin resistance is, what I'd like to do first is to look at what the normal function of insulin in the body is. So what insulin essentially does is it moves sugar from our blood into the cells. So in this cartoon here, insulin is shown in red and the glucose is shown in these green circles. So what happens is that after we eat, our blood sugar levels rise and our pancreas produces insulin, and insulin travels in the blood and binds to the cells, and most of the sugar is taken up by our muscle cells. And what insulin does is it attaches like a key would fit into a door lock, and then it unlocks and opens doors through which sugar essentially passes from our blood into the cells. So this is the normal function of insulin, and this is how we basically maintain our normal sugar levels. So what happens is that in insulin resistance, the normal amount of insulin that we produce is not sufficient or enough to open or unlock these doors through which sugar is passing into the cells. So to prevent sugar from building up in the blood, our pancreas produces more insulin. And when we have more insulin, we're able to open these channels or doors through which sugar gets stored into the blood, from the blood into the cells. So essentially, a person with insulin resistance, their cells are less responsive or resistant to insulin, mainly our muscle cells, and our body produces more than normal amounts of insulin to keep our blood sugars normal. So as long as we are able to do that, our sugar levels remain normal, and it's at the expense of higher levels of insulin in our blood. But in some people, this condition can lead to diabetes. And what happens is when our pancreas cannot produce enough insulin, this slight decrease in insulin basically doesn't let all the channels for the sugar uptake to open, and the sugar levels in our blood essentially go up gradually. So this process happens over months and years silently, and what it leads to is that our sugar levels in the blood rise, which first leads to development of prediabetes, and eventually, which is levels of blood sugar that are higher than normal but not high enough to be called diabetes, and eventually a person develops diabetes. So the presence of diabetes basically results from insulin resistance and not having enough insulin in the blood, although it's still higher than normal. So these two conditions, insulin resistance and not having enough insulin, becomes a risk, leads to diabetes, and diabetes is essentially a risk factor for heart disease. But what happens is that most of the people with insulin resistance continue to produce enough insulin. And the combination of high insulin and insulin resistance leads to what we call insulin resistance syndrome, which increases the risk for heart disease. So what is insulin resistance syndrome? It is essentially insulin resistance along with high blood levels of insulin. And what happens is when our body has higher than normal levels of insulin, our liver starts to produce more triglycerides, which are type of fat in the blood, and triglycerides circulate in the blood along with cholesterol, and when we have higher levels of triglycerides, this extra cholesterol can be deposited into our blood vessels, and it can become a risk factor for heart disease. The other thing that happens in insulin resistance syndrome is that we have low levels of good cholesterol, and we are also prone to develop high blood pressure. And we have somewhat higher blood sugar levels. So all these abnormalities together by themselves or in combination increase risk for heart disease. So insulin resistance leads to diabetes and heart disease. And so what I'd like to show you next is that South Asians as a group are more insulin resistant than other race ethnic groups. So this is a study that we did at Stanford where we measured insulin sensitivity or insulin resistance directly by giving sugar and insulin into the blood. And the measure of insulin sensitivity or insulin resistance in this case is shown over here, called the SSPG. The higher the number, the more insulin resistant the person is. And what we found that South Asians in our study were more insulin resistant than people of European origin. So the question arises that what essentially determines insulin resistance? So there are factors that we inherit. For example, belonging to a high-risk ethnicity, South Asian or East Asian, makes it more likely that a person will be insulin resistant. Other factors such as having a family history of diabetes or high blood pressure also makes it more likely to be resistant to insulin. But the two factors that contribute the most to this condition are physical fitness and body weight. So when our physical fitness is lower and our body weight is higher, we tend to be more resistant to insulin. So, and these are the two factors that contribute the most and are the ones that we can change. And the relationship between the two is not one-to-one. So it doesn't mean that everyone who is overweight is insulin resistant, but it makes it more likely to be that. So insulin resistance essentially is a condition when our cells are less responsive to insulin and we have higher than normal amounts of insulin in our blood. And it can lead to diabetes and heart disease, and South Asians are more resistant to insulin than other race ethnic groups. And we just looked at the factors that contribute to insulin resistance. So how can we be more aware of the presence of insulin resistance? So the first thing we do is we look at the factors that we inherit, for example, belonging to a certain race ethnic group or having a family history of diabetes. So if we have those, we can be more aware of the presence of insulin resistance that will make it more likely to have that. And the other two factors are physical activity level and our body weight. So in general, individuals who are sedentary or have a higher weight would be more likely to be insulin resistant. And the other factors, two things that we can easily measure in a clinic, are a body mass index, which is basically our weight in relation to our height. And for South Asians and East Asians, it's recommended that a body mass index of 23 or higher would put someone at a risk for this condition. And the other thing that we can easily measure is the blood pressure. In addition to those things, there are simple measures that we can make in the lab that include triglycerides, which are a type of fat in the blood, higher levels of triglycerides, low levels of good cholesterol or HDL cholesterol, and higher levels of glucose will, again, make it more likely to be insulin resistant. And lastly, what we do is we sometimes, although not commonly measured, is the insulin that can be measured in the blood, either in the fasting state or in response to a glucose tolerance test where we give you a sugar drink and then we look at the amount of insulin you produce over 2 to 3 hours. So knowing about all these risk factors, some of which we have because of our history, and then lifestyle factors and things that we can measure in the clinic and in the lab, we can get a fairly good idea about, or we can identify people who might be resistant to insulin, and identification of that can basically help us control these risk factors and prevent the disease. So heart disease is common in South Asians. South Asians are more insulin resistant as a group and therefore at higher risk for heart disease. And simple clinical measures such as blood tests or measurement of blood pressure or body mass index can alert us to the presence of insulin resistance. So I'd like to stop at this point.
Great. Well, I'd like to just start by adding my welcome and thanks. Thank you again for joining our inaugural Stanford Medicine Health Fair. My name is Srinalam Shetty. I'm one of the cardiologists at the SSATHI Clinic. And I'm going to be talking to you today about challenges surrounding cardiovascular risk prediction in South Asians. And there will be quite a bit of overlap with what you've heard from Dr. Basi and Dr. Dash, but hopefully this represents an opportunity for us to consolidate some of this information. So I wanted to start also by providing a bit of perspective on how substantial the risk of coronary artery disease is in South Asia. So if you looked at cardiovascular disease trends over a 20-year period spanning from 1990 to 2010, globally there was close to a 40% increase in incidence of coronary artery disease. Now if you looked in South Asia, the numbers are staggering. It's closer to 80%. And what drives that? Well, South Asia accounts for 60% of the global burden of coronary disease, and that's in spite of the fact that it contains only about 20% of the world's population. So there's a huge disproportionate risk and burden that's driven, as you've heard from Dr. Dash, by more coronary deaths in South Asia, South Asians developing disease 10 years earlier. And this phenomenon actually translates to immigrants from South Asia that move to Europe and North America. They have higher rates of cardiovascular disease and die from coronary disease at younger ages. Before we launch into the specifics of how we assess and predict risk in South Asians, I think it's important to have a good working understanding of the risk factors that drive coronary artery disease. And they can be broadly classified into two categories. And you've heard a little bit about this from Dr. Dash and from Dr. Basi. We have the traditional modifiable risk factors that include things like high blood pressure, tobacco use, diabetes, cholesterol problems, sedentary lifestyle, and poor dietary choices, and obesity. And we call them modifiable because they can be addressed through pharmacological measures or drugs or lifestyle changes. And by doing that, you actually have the opportunity to intervene on these risk factors, control them, and then in turn mitigate your risk for developing coronary disease. The second category of risk factors are the non-modifiable risk factors, and those are things like age and gender, family history, and as you heard from Dr. Basi, also ethnicity is increasingly recognized now as an important non-modifiable cardiovascular risk factor. So how do these conditions and lifestyle issues conspire to create coronary plaque? Well, hypertension or high blood pressure, diabetes, and tobacco use over time damage the lining of blood vessels. And this creates a local inflammatory reaction that allows cholesterol to actually enter the vessel wall and accumulate and ultimately form plaque that can over time ultimately lead to complete obstruction of blood flow. We talked a little bit about lifestyle factors like diet and physical activity. Inactivity, how do these fit in? Well, it turns out that those issues can contribute to the development of diabetes, hypertension, and cholesterol problems, and can lead to obesity, which in turn can also create problems with cholesterol, diabetes, and hypertension. So you have sort of a multiplicative effect. And this slide really emphasizes the importance then of intervening early, identifying risk factors, and developing an individualized approach to treatment and risk assessment. So South Asians are unique in a number of different regards. One of them actually centers around how risk factor profiles look in South Asians. There are a few of them that include tobacco use and weight that actually are less prevalent in South Asians. And if you look at rates of hypertension, they're similar with Caucasian counterparts. But in spite of this, we have a 2- to 4-fold higher risk observed of cardiovascular disease. But there is higher prevalence of diabetes and insulin resistance, as you've heard about from Dr. Abbasi. And in general, South Asians, when this has been looked at a population level, are more sedentary and have diets that are rich in refined carbohydrates. This is a bit of review from Dr. Abbasi, but I'll just go through quickly again a couple of key points. So blood glucose, as you heard, is controlled by multiple organs. So the main source of glucose is our diet, but the liver actually also produces some glucose that enters the bloodstream. When glucose enters the bloodstream, as you've heard, it increases insulin secretion, which then encourages glucose to enter various tissues, mainly muscle and fat, where it's used as a fuel or stored. Now, in insulin resistance, we see abnormal fat accumulation both in the visceral depots and the subcutaneous depots, as well as in muscle and in liver, and this leads to dysfunctional activities that ultimately lead to require higher levels of insulin, and this leads also to higher levels of glucose circulating in the blood, but this ends up actually just being literally the tip of the iceberg. When your body is not able to process and use insulin in a normal fashion, it develops maladaptive mechanisms to compensate for this. So because cells are not seeing and receiving enough insulin, the body mobilizes fatty acids, and those levels are increased in the circulation. And those have important deleterious effects. They further complicate insulin resistance issues. They cause inflammation in fat and in other organs. Blood triglycerides, as you heard, are also elevated. And we see lower levels of good cholesterol in that context and higher blood pressure. And we do see this progression of disease from insulin resistance to prediabetes and then ultimately to diabetes, typically over many years. But it's crucially important, again, to emphasize the point that patients have the same risk of developing a heart attack or stroke if they're insulin resistant, more or less, as they do when they have frank diabetes. So this really emphasizes the importance of identifying that particular risk factor in our South Asian population. So what are the tools for diagnosing diabetes and insulin resistance? Typically in the clinic, many of you have had this experience, you'll just get a fasting blood glucose. And if it's above 100, it's referred to as impaired fasting glucose. If you're above 126, you're considered to be diabetic. It's a quick and easy test, and that's why many of the societies encourage using this as the primary screening tool. But as you've heard, we actually employ, in addition to checking a fasting blood glucose, the oral glucose tolerance test, which requires a significant glucose load and a 2-hour time commitment. And if you have a 2-hour glucose of greater than 140, you're considered to have impaired glucose tolerance, and if it's above 200, you're considered to have diabetes. And what are the important distinctions of note here? Well, it turns out that OGTT is more of the gold standard. It captures more patients that have insulin resistance and prediabetes than fasting blood glucose. A1 testing can be helpful, as Dr. Dash had mentioned, and we can also diagnose diabetes if you have a random glucose of 200 and typical symptoms consistent with diabetes. And getting back to this issue of why South Asians develop insulin resistance. So although on average South Asians weigh less, they have a distinct body composition type, and it's called the thin fat body composition. So although they have lower BMIs, they have more truncal fat or visceral fat, as we've talked about, and they have a lower ratio of lean muscle, which burns calories and sugar, to fat. And so this ends up creating a higher waist to hip ratio, higher fat content in the muscle and liver. And these issues, when combined with the carbohydrate-rich diets and sedentary lifestyles patterns, complicates issues and culminates in South Asians developing insulin resistance and diabetes at lower BMIs and at younger ages. So let's talk a little bit about assessing diabetes risk in South Asians. So we know they have a 6-fold higher risk of diabetes, and you've heard this number of 23, but more recent data suggests that South Asians may actually be at an elevated risk for these conditions with a BMI as low as 21, which when you consider in Caucasian populations is really as close as you can get to a normal body weight. If you have a waist size of greater than 35 inches, it demarcates a risk for diabetes. A waist to hip ratio of greater than 1.2 or a waist circumference to height ratio of greater than 0.5 also predict risk. And hemoglobin A1C alone may miss some cases of diabetes, and there's been recent data to suggest that we should probably modify our cutoffs for hemoglobin A1C as well in the South Asian population. There was a large study out of Chennai that showed that patients that had impaired glucose tolerance had a cutoff of actually 5.6 as opposed to 5.7 for prediabetes, and that patients that had hemoglobin A1Cs as low as 6.1% had frank diabetes on OGTT testing. All important factors to consider. So what are some of the challenges with assessing cardiovascular risk in South Asians? And Dr. Dash referred to some of these issues. But it's important to understand that our current risk prediction tools include statistical models such as the ACVD model that Dr. Dash walked you through, and blood tests. But the important limitations to emphasize in this context is that a lot of these risk prediction tools and markers were derived from data from non-Asian cohorts. And the risk factors relevant to South Asians are not appropriately weighted in these risk factor models. So let's talk about the Framingham risk score, which over the last 30 to 50 years has perhaps been the most widely used one. It looks at age, gender, tobacco, total cholesterol, your good cholesterol or HDL, and blood pressure. The Reynolds risk score adds an inflammatory marker, C-reactive protein, and family history, so it has some incremental benefit. And the Q-risk-2 score, which was developed in the United Kingdom, is actually the only one that has a specific question pertaining to South Asian ethnicity. And it has a more extensive list of clinical conditions that are considered when we're calculating cardiovascular risk. And then you heard a little bit about the ASCVD score, which also includes diabetes and ethnicity, but not specifically South Asian ethnicity. So only the Q-risk, in summary, Q-risk-2 score considers South Asian ancestry. The Q-risk-2 and ASCVD scores include diabetes in the risk assessment. None take into account insulin resistant and prediabetes. And none take into account important anthropometric measures such as waist to hip and waist to height ratio. So is the Q-risk-2 score the best available tool for South Asians? You would think so, but it still also severely underperforms in South Asians. So if you look at predicted to observed risk ratio in South Asian women and South Asian men, the values are 0.52 and 0.71. So what does that mean? So if we saw a patient, a South Asian woman in clinic, and we plugged her score or calculated and generated her score using Q-risk-2, that predicted score only captures about 50% of the actual risk that woman will have. Similarly, for a South Asian man, we're only capturing 70% of that risk, so we're missing 30%. So in many regards, we're leaving a lot on the table, so to speak. And I wanted to just present the case of an individual that I saw in clinic just a couple of weeks back to illustrate this point for you. So this was a 46-year-old. He had a history of mild impaired fasting glucose, high cholesterol that was that was being treated with a statin medication. He had borderline hypertension and a very strong family history of heart disease and diabetes. So a quick pop quiz. If I asked everyone in the room to classify this patient either as high or low, maybe I can have a show of hands for low. Okay, great. Everyone passed the pop quiz. How many would say that this is a patient at high risk? Right. So it's interesting. So if you go through the risk prediction tools here, as Dr. Dash had demonstrated, a Framingham 10-year risk score only calculates out to 2%, which classifies them as low. Now, there have actually been studies done that show that individuals of South Asian descent probably have a vascular age of approximately 10 years above what their chronological age is. So if you were to add 10 years to this patient, he would come out to have a risk of 5%, which likely still underestimates his risk. The Q-risk2 10-year risk score is 6%, and that still only puts him into an intermediate risk category. And the Reynolds and ASCVD pooled cohort risks are also going to classify him as being low. Now, there are important serum biomarkers that have been shown to be specifically elevated in South Asians, and you've heard a little bit about this. In the interest of time, I'll just put this list up here and move on. So, in summary, we know that the traditional risk factors fail to fully capture cardiovascular and diabetes risk in South Asians. Guidelines advocate for initiating treatment based on risk factor assessment. So, according to our guidelines, we should only be prescribing statins and other cholesterol-lowering therapy if the 10-year risk is greater than 7%. So our patient on the last slide would actually miss that cutoff. We would consider using anti-diabetic drugs in insulin resistance, but the most commonly prescribed screening tool for that does not perform well enough in many circumstances. So there are important gaps in risk assessment, diagnosis, and treatment. And this is where I think the SSATHI approach is worth emphasizing. So it's really centered on understanding in a more global and individualized perspective your overall cardiometabolic risk. So we emphasize testing for metabolic dysregulation and detecting insulin resistance in prediabetes. We incorporate, as part of your initial assessment, anthropometric measures such as waist to hip and waist to height ratios. And we include the assessment of novel blood tests and biomarkers of disease that are known to be elevated in South Asians, and use advanced imaging techniques such as coronary calcium and carotid intimal thickness testing, which many of you may have had today when clinically indicated. And we couple this assessment, as you heard from Dr. Dash, with individualized treatment plans. And just in the interest of time, you've heard a little bit about this, but this is an overview of our strategy over the course of our 6-month partnership if you come to visit us in clinic. And with that, I'd like to just thank you again for your attention, and we'd be happy to take questions.
South Asians, when we talk about South Asia, I mean our culture, our diet, and so on. And if I just look at India, we have 29 states now. The people in Assam and the people in, let us say, Tamil Nadu,
Yes.
they compare to the North Indians, including Pakistan. How do we compare?
So
The diet is very important.
yeah, diet is certainly important. And I don't think there has been, to my knowledge, careful assessment of regional differences. I don't know, Raj, if you're aware of data that has looked specifically at South versus North.
Yeah, actually there are very detailed maps that look at the incidence of cardiovascular mortality broken down by state. And there are certain hotspots, both in the north and the south. However, you may have heard that South India has a particularly high incidence, and that's true. Kerala and some of the southern states definitely have, and it's believed to be somewhat diet-based. However, there are also hotspots in Punjab and in northern India as well. So I think that it does vary. That data is available. It's interesting, in India they haven't done some of the comprehensive studies that we would have hoped to have been done by this time, but they're starting to, and some of the literature is starting to show this work, which is going to be very valuable to identifying regional differences. But at the moment, we are somewhat resigned to lumping all of South Asians into a high-risk group, and truth be told, even the lowest risk states in India are higher than most places in the world. So.
Indians, right? Because our arteries are small.
I think, so, I mean, I think what you're illustrating is important. I think that, you know, with South Asians, there has to be a higher level of suspicion,
Correct.
even for, you know, for age-matched people of other ethnicities, and that's just borne out by all of the data that we've shown to you today. And I think if you can, you know, pursue that type of an evaluation through your physicians, I think that's going to be ideal. And what we're doing in our clinic is exactly that, which is having a higher degree of suspicion, a higher degree of investigation and aggressive screening and treatment for what we hope to be precursors to active disease, as opposed to uncovering active disease right at that time.
Two things, because after that event, I had probably the worst heart attack in my life, they told me. Fear was on me. So basically, I had numbers that was the worst, you know, 10 times, 20 times on the troponin numbers and everything. Eventually, they saved me jerry-rigged two stents, and they said I lost half my heart, probably looking at a heart transplant. And I was sitting there and I Googled, I was trying to get all the pure on Googling, and I found out about a stem cell study that's going on. I think one of your teammates or the Marvin study at Beverly Hills. I signed up, and they had a new study that was going on. I signed up. My friends told me don't do it, but I went in and did it. They gave me I went into a clinical trial, they gave me a single shot of stem cells, and I recovered 50% heart. I probably had a bigger heart than I had before. They say it's the first regenerative, serious case of heart was totally regenerative. Johnson & Johnson has put $300 million in to do more trials.
Okay, I think we'll have to move on to some other questions here, but thank you very much. So I think we have a whole list of questions from everyone, so I don't want to lose out on that opportunity to answer them. Do you guys want to start with one of yours?
Sure.
Yeah,
I can start with one. So the question is high triglycerides greater than 500 genetically determined? And is it possible to investigate this at our SSATHI clinic? And so, great question. There has been some debate over the years about the role of high triglyceride levels in coronary disease. But as the data has settled out, I think the general conclusion is that high triglycerides are associated with higher incidence of coronary events. And so it's important for it to be on your radar screen. There are multiple factors that determine that level of hypertriglyceridemia. Certainly there are genetic factors, but typically when you get into a very high range, there is a significant contribution from diet. And interestingly enough, it's not so much diets that are high in fat that drive this. Usually it's a diet that's high in refined sugars, because refined sugars are very quickly converted into triglycerides and then stored. So when we evaluate patients, and we certainly do in our clinic with high triglycerides, we really do screen for both genetic as well as environmental factors, including diet, that might be contributing. It's quite common that patients that have poorly controlled diabetes end up having very high triglycerides. Sometimes patients with thyroid problems also have this as a complication. So as part of a comprehensive assessment, we would look into all of those factors.
Do you want to go with yours?
Yeah, so the question is what medications to treat insulin resistance? So currently there are no medications that are FDA approved to treat insulin resistance, and what we recommend is that all of what we do is that the risk factors that are associated with insulin resistance should be assessed and treated, and that's one thing. So if someone has high blood pressure or high triglycerides or low levels of good cholesterol, they should all be treated to bring them to a desirable level, or if the sugar levels are high, they should be treated. The other thing that definitely helps insulin resistance, has been shown in several studies, is being more physically active and weight loss, if that's applicable. So the medications that are available that make our body more sensitive to insulin are usually used for patients with diabetes and are not currently available for people without diabetes.
Okay. So I have a very good question here. Actually, two people wrote the same question, which is, do children of Indian parents born in the US also have the same risk as their Indian parents? And then the other question was very similar, first and second generation immigrants to the US. So it's an excellent question. It's one that still there's a lot of unknowns about that. But what we are seeing is that the incidence of coronary disease is very similar in India as it is to here. That's quite high and higher than the ethnic populations that are living in the same regions, like for instance in California. And so our thoughts, our experiences with this is that we're seeing a lot of first generation and second generation patients in our clinic, all with very similar levels of risk factors, but there has not been a clear study that has looked at first and second generation immigrants, and that's something that we may be able to do down the road here.
I'd just add also, Roger, it's important to appreciate in this context that there are both genetic factors and environmental factors that are important. So there's a genetic basis to this high risk for insulin resistance and cardiovascular disease. And when individuals of South Asian descent immigrate to Europe or to the US, they often adopt what are traditionally called Western lifestyle patterns, which are to a large extent characterized by diets that are rich in fat and refined sugars, and also sedentary lifestyles. So it's not as if you're moving from one region to another region that completely transforms that piece of the equation. You essentially translate that genetic predisposition to another environment. And there are a number of interesting theories about why South Asians have this increased risk of diabetes, and part of it, may actually have to do with nutritional factors back home. So there's clearly lower birth weight in South Asians, and this has led to the thrifty hypothesis, the idea that in utero you're seeing less nutrients, and so you have a genetic program that actually encourages storage of calories and excess energy, and this might be piece of the equation when we consider and try to understand why South Asians develop more truncal obesity and accumulate more visceral fat.
Thanks. And one other thing I wanted to get back to Fahim's response to the insulin resistance question. While there aren't any FDA-approved treatments for insulin resistance specifically, part of that is because they haven't really been studied for that purpose specifically. And one of the things that we hope to do in this population is be more aggressive with treating insulin resistance. And if necessary, in severely insulin-resistant patients, if we don't have hope that lifestyle and diet alone may work, we may be instituting that kind of a treatment because we are left with that as our options to prevent some of the adverse clinical outcomes from insulin resistance.
So I have perhaps an important question we should have addressed more explicitly at the start. The question is, what specific ethnic groups are considered as being South Asian, both region and country? So it really refers to individuals of Indian, Pakistani, Nepali descent primarily, but also Bhutan, as well as Afghanistan,
Bangladesh.
And Bangladesh, exactly. And those are the, and Sri Lanka as well, absolutely. Sorry? Bangladesh, yes, we mentioned, yes. Yes, the entire Indian subcontinent, including Afghanistan and Bhutan. And the second question is, are South Asian females of higher risk than South Asian males? The answer to that question is no, but what we do know is that it is more difficult and more challenging to predict risk and to effectively address it in South Asian females than it is in South Asian males.
And why is that? Could you explain that, why that is the case?
So we don't understand that. We don't understand that. there are many potential theories, but nothing that I think we could confidently present.
I'm sorry to bring in sexism, which is very big in India, almost everywhere. When a child who is a female child falls ill, oh, my people will get rid of her, not their body. I'm just joking. But people are not taken. Wives are ill, they don't go to the doctor. But the husband is ill, they do go to the doctor. So it may not happen.
Yeah, I think that there is, and I don't think that we have any clear data to prove what we're seeing and what you're saying, but I think it's sort of our obligation when we see female patients in our clinic that I am actually have a higher degree of suspicion by sort of a force of will to make sure that I'm not missing that type of a risk, because I think that across the board we are perhaps getting some underreporting, and I encourage, as I said, when I have my patients, a lot of my patients come in and they bring their wives with them, and I'm asking at the end of the visit, I'm like, have you also been screened? And do you also have family history? Because otherwise I feel like they may never come to our attention. And I think that that's something that is perhaps cultural. I don't know that for sure, but I think that is something we do observe. So.
Well, it looks like there are a number of organizations dealing with this issue of associations with heart attack. One is the Prana from Palo Alto Medical Foundation. There's a South Asian Heart Center, and I hear about this. Is there any plan to integrate all these things? Because I believe the emphasis on each of these is slightly different than the others. Yours is, definitely different than the other two, I know.
Yeah, I can answer that. So the question was, we're not the only South Asian health center or clinic in the Bay Area. There's one at PAMF and there's one at El Camino, and they are slightly different. Prana isn't so focused on cardiovascular. They're sort of focused on general health. El Camino is not a clinic. It's a center, and it's a screening service and a lifestyle coaching service. And it's been around the longest. It's actually, done some amazing work. And yes, so the leadership of each of these groups, we've all been talking and trying to get some sort of integrated plan going. I think that would be an awesome approach, especially given each of our respective expertises. I think that we offer something unique in terms of the long-term clinical care, as well as the research side of our program, which is leveraging a lot of what Stanford brings to the table. But they also have their own strengths that we don't need to reinvent the wheel in that regard. And we've certainly learned a lot just from what they've already done. And a lot of our Stanford faculty actually have published with data from the El Camino Center. I think that's not to be forgotten. I think that there's a lot of value on having us work together down the road. Yeah. So I think some of these have already been answered. Why do Indians have a high risk of heart attacks? I think we've.
So I have one question that hopefully will be relevant and important to address. So I'm 61 and have heart disease and diabetes. Can I still be part of the program? Absolutely. Yeah, that would be an unequivocal yes. So part of the big thrust of our program is to identify risk factors early and to treat them to prevent disease. But we really do feel that we have an important role to play in secondary prevention as well. So I think we'd encourage patients with established disease and issues to come as well, because I think we'll be able to offer a lot in terms of nutritional counseling, lifestyle modification, and then a more aggressive, targeted, and individualized approach to pharmacological therapy.
There's a question here. I have my insurance with Kaiser, so how would it work for me to come to SSATHI to be evaluated and treated? It's a little trickier. I think that the patients that we're seeing have all registered as Stanford patients, and whether that's allowed by their insurance or not is a case-by-case basis, and if they're not already in our network. However, we, as I mentioned, have a lot of research that we're undergoing and that research is not billed to insurance. So that is an avenue for you to have some studies of ours done. And if you have a physician at a different network like Kaiser who's willing to work with us, we can certainly speak with them, maybe give them some recommendations about what we might want to do, but we may not be able to actually provide that clinical side of the program as we would normally do. So there are some possibilities, some avenues to being involved with our clinic.
And this also answers the question, how do I participate in a research study? So in the SSATHI clinic, we've started a few research studies that you could come in and volunteer for, and that's one way. And the other is that we often advertise in local papers and local media about any studies on insulin resistance.
Can you give a phone number that you can call for the participants?
Yeah, so actually there's a whole table downstairs with packs of flyers if you do want information, and so that's something that you can just get right downstairs, as well as our business cards and things like that. So those are all available down there.
There's one comment I want to make, very important, which is that in many cases, I know 20% of the population today is from patients. No matter how many Indian doctors are here, but most of us visit like in follow-up, and I find the doctors there are lacking information on sortation. And I think there should be something done in this area that you have these patients coming. You've got to know about who we are.
Yeah, so
Because I am finding very dissatisfaction there for them to know what are the risk factors.
yeah, so the comment was that in your experience, you've seen that some of the physicians you've encountered aren't as well informed about South Asian risk as maybe you would have hoped. That's why this clinic was started, because I think that the problem is pretty severe. It's not something that we're taught about in medical school. It's not something that we're taught about at all, really, unless you seek out that information specifically. And it's something that was started, as many of these places were started, because of an observation by South Asian physicians typically, saying there's a need for this type of thing.
What I'm trying to suggest is Stanford can take it as kind of a responsibility, the greatest medical institute, that invite them to participate as doctors and know about what you're doing.
Sure. I think we have that plan. Yeah.
Yeah, we completely agree. I mean, I think part of this effort is really spreading the word and educating both patients and physicians. And so Raj can speak more about our Back to Heart series, which are outreach programs where we have the opportunity to meet with and convey some of this information to physicians, specifically in the South Bay. The idea, as the clinic evolves, is to expand that education program. I don't know if you had any additional thoughts.
Oh yeah, absolutely. And a lot of our corporate partners here so there are many, and here in the Bay Area have their own wellness centers, and so we go out and speak to those physicians to let them know about this sort of unique problem and unique population, and they're all very receptive. It takes time, and down the road we actually hope to have a symposium specifically for SSATHI that we will be inviting, hopefully, members of the community, providers, potential non-providers who just want to learn about the problem, as well as thought leaders in the field from across the country and around the world. So this is something that's just getting going, and we're really excited about hopefully sharing that knowledge with everyone. So
I have a multi-part question that's quite good, that I think is important to address. So the first question is, what is the best combination drug with statin? Niacin, fenofibrates? And the answer is probably neither of those. So, and this is actually a relatively recent development. So both niacin and fenofibrates have been studied in combination with statins in the last decade or so. And so there have been 2 big niacin trials that have clearly shown that there is no benefit of adding niacin routinely to a statin. For fenofibrates, the story is a little more complicated. There might be subsets of patients that will benefit, and that subset specifically refers to diabetics. So if you're a diabetic and you're on a high-dose statin and you haven't attained your goals, the question of what the appropriate goal is a more complicated one that is beyond the scope of addressing in this session. But you might benefit from being on a fenofibrate. Now, the most recent trial of note with regards to this question is the Improve It trial, which looked at adding a drug called ezetimibe or Zetia, and it works in a completely different, through a completely different mechanism. It actually blocks cholesterol uptake in the gut. And this was actually the first remarkably positive trial in the last 10 or 15 years or so looking at combination therapy. And what they found was that if you added Zetia on top of a moderate dose of simvastatin, that you actually derived a clear and measurable benefit over the course of 3 to 4 years of follow-up. So in response to that question, it's probably at this point the best available data would suggest that it's actually Zetia or ezetimibe. The other part of the question is, how do you determine Lipitor dosage and based on what levels? So I was trying to avoid answering that question about levels, but maybe we can delve into it. So just last year, the ACC and AHA and NHLBI put out a new set of guidelines which actually de-emphasized checking cholesterol levels and emphasized patient clinical characteristics. So we know that you should be on a statin if you meet a couple of conditions. If you have had a heart attack before, if using these prediction tools, your 10-year risk is greater than 7.5%, if your LDL cholesterol is greater than 190, and if you have diabetes. They further go on to say that based on the best available evidence, that the dose or intensity of treatment should also be dictated by similar considerations. So if you're a diabetic, you should be on at least a moderate intensity statin, which is Lipitor of 20 or simvastatin of 40 or Crestor of 10. If you've had a heart attack or a stroke, or if you have peripheral vascular disease, circulation problems in the extremities, then you should be on a high intensity statin. So Lipitor of 40 to 80, up to 80, and Crestor of 20 to 40, and simvastatin of 80. We're using simvastatin at a dose of 80 less because that's associated with more complications with regards to muscle damage and inflammation. So the long and short answer, I guess, is it's really going to depend on, 1, your clinical profile, and 2, your ability to tolerate a specific dose.
So I have a question here. Is free fatty acid level in blood a risk factor independent of triglyceride level? So it's a good question. So the answer is free fatty acids are not a recognized risk factor. However, free fatty acid levels, free fatty acids are essentially building blocks of triglycerides. So they make up the triglycerides, and their levels are higher in people who are insulin resistant, along with triglycerides. And when our free fatty acid levels are higher, and our insulin levels are higher at the same time, we're more likely to have higher triglycerides. So it makes sense from that point of view. And what they basically, higher levels of free fatty acids, what they're indicating is some degree of insulin resistance in our fat tissue that is not normally responding to insulin. So it's sort of like a marker of insulin resistance, but it's not currently recognized as a risk factor that we can sort of change and lower risk for heart disease or diabetes.
And I have a question here. Why do Indians have a tendency for diabetes or prediabetes? Is it food habits in their early life, or hereditary from past generations, or both? I think that the answer is that it is almost certainly both to some degree. There's when you look at it, the incidence of prediabetes and insulin resistance is so much higher in this population, it would be difficult to argue that it's simply lifestyle and diet, that there may be some genetic factors that are pushing that along, and the lifestyle and diet that maybe is adopted through changes to the Western style more, or more of the native types of diets may simply promote the development of it with that genetic background. And I think that there's a lot of work that needs to be done in terms of looking at propensity to develop insulin resistance and whether there are mutations that might promote that we could track through families and things of that nature. Those require lots of patients and lots of genetic analyses in terms of a genome-wide association, but that's something that would be wonderful to do. And right now, when you look at cardiovascular risk in the South Asian population, there's a new database that's being created globally, and biobanking of genetic and sort of blood-based laboratory results that is worldwide. And right now on that level, the South Asian population is essentially not represented at all. And it's a huge hole in this database, and it's something that is part of our long-term mission, is to start developing that database in India and other parts of South Asia, because in terms of cardiovascular risks, there is no other higher risk population, and it's completely not being represented in that type of an analysis right now.
So I have a question here. Can LDL particle B be reversed? And the answer is yes. And it's LDL particle B is usually related with triglyceride levels, and any treatment that lowers triglycerides can definitely lower the levels. And the other question is, how long on average does it take to develop diabetes after diagnosis of prediabetes? And the process of developing diabetes is slow, and it can take several years, 5 years or longer. But basically what it indicates is that people should get their sugar levels checked on a regular basis, so that if there is an upward trend in the sugar levels rising, then we can intervene and sort of assess that as time passes.
And then I see this other question on his sheet: is calcium scoring helpful? Actually, just a few months ago, I think in sort of fall of 2014, there was a publication that was actually published by the group at UCSF. The Masala study looked at calcium scoring in South Asians and whether that correlated with cardiovascular risk. Now, it wasn't a prospective study. It wasn't looking at, okay, you have this calcium score and we'll follow you for 10 years and see if you have a heart attack or not. It was a retrospective study and just basically looked only at risk scoring, not at risk events, not actual events, rather. So they basically found that, yes, calcium scoring does correlate with other risk scores within that population. So there is a value to having the calcium score. I think that there's more work to be done in that regard to see if it truly is predictive of events on its own, but it does correlate with overall cardiovascular risk.
Probably just add to that also that it may have a specific role for patients that come in and have what we classify as intermediate risk. And what we know is that some proportion of patients that get classified as intermediate risk probably deserve to be on statin therapy. And so the coronary artery calcium score can help modify that and reclassify an intermediate risk patient either as being low risk, in which case we can be more confident in our decision to withhold that therapy, or actually, in many cases, high risk. And so when you get reclassified as high risk, it's more ammunition for really moving ahead with therapies. So I have just one, maybe I'll squeeze in one last quick question here. Can inflammation in the joint off and on cause abnormal blood sugar and A1C? So that's a complicated question to answer off the bat, but I would say that it's unlikely that inflammation in the joint in and of itself, depending on what's actually causing it, could drive up blood sugar or A1C. It is important to note that there are some forms of arthritis, such as rheumatoid arthritis and what we call seronegative, which are rheumatologic conditions as well, arthritis, that are associated with elevated cardiovascular risk. So the concept of having systemic inflammation that might affect the joints is an important one because that's likely also affecting the blood vessels. And as we talked about, an inflamed blood vessel with a damaged lining is more likely to develop plaque.
Yeah, I think that's it. Thanks.
Thank you.
Thank you.